Welcome to a deep dive into something really fundamental and often debated.
hmm
What does equity of access to medical care actually mean? And how have we tried to get there?
Yeah, it's a huge question. We're looking today at a really key paper from 1981 by Lu Ann Aday and Ronald Andersen.
Right.
It unpacks the ethics behind equitable healthcare and then hits us with some real-world data from back in the late 70s.
So our mission today is to pull out the key ideas from this work, get a handle on how equity was defined and measured back then, and see what trends and maybe persistent challenges were already visible, over 40 years ago. Let's jump in.
Okay, so the paper kicks off with three core assumptions, pretty foundational stuff. First, this idea that healthcare is often seen as a right.
Okay.
Second, healthcare resources aren't infinite, they're scarce.
Always the kicker. Yeah.
Exactly. And third, because of that scarcity, health policy needs, well, just ways to decide who gets what. And that tension right there between a right and limited resources, that's where the ethical wrestling really starts.
That makes sense.
Yeah.
Now, the paper draws a really interesting line between the right to health and the right to health care. Why is that distinction so important?
It's crucial because a right to health, how could a government guarantee that? It involves so much personal behavior, genetics, environment.
Right, too many variables.
Exactly. But a right to healthcare, that's about access to services. That's something policy can actually, aim for and try to deliver. More manageable.
Got it. And for that just allocation, they push back against ideas like merit or who contributes most to society, right?
They do. Instead, they zero in on two main criteria. First is need. Simple but powerful. Services should go where the need is greatest. Think like Rawls' ideas of social justice.
Okay. Neat. What's the second one?
Similar treatment for similar cases. Basically, things like your income or your race shouldn't dictate whether you get care or how good that care is if you have a particular medical issue.
So, same condition, same treatment pathway, ideally.
That's the ideal, yeah.
Okay, principles established. Let's get into the data. What did those national trends, say, late 50s through the 70s, actually show? Was there progress?
Oh, definitely. Big improvements. Groups that had traditionally been left behind, the poor, non-whites, saw significantly better access.
And that was linked to specific policies.
Yeah, largely credited to Medicare and Medicaid coming online in the mid-60s. Those programs really did move the needle, at least initially.
Sounds positive. But I sense a but coming. Were there still stubborn gaps?
Absolutely. The data showed lingering inequities. For instance, poor individuals were still much less likely to see a dentist compared to the non-poor, or to get prenatal care in the first trimester.
Crucial preventative stuff.
Exactly. And another big one, less adequate third-party insurance. So even if they got care, they potentially faced higher out-of-pocket costs.
Okay, so access improved, but maybe not equally across all services or financial protection. What about how often people used services?
That's interesting, too. Physician visits, hospital stays for the poor, they jumped up dramatically at first. But then those gains kind of plateaued or even dipped slightly relative to the non-poor by the late 70s.
Huh. What do you think that was?
The paper doesn't fully explain that dip, but suggests maybe initial pent-up demand was met or perhaps other barriers started emerging. But there was a really encouraging finding from 76.
Oh, yeah.
Yeah, when they looked at why people went to the doctor adjusting for health status, poor individuals were seeking care for symptoms almost as appropriately as higher income folks. That was a huge change from the early 60s when need didn't translate well into access for the poor.
So better alignment between need and actually seeing a doctor.
Yeah.
That is significant. But were these national improvements hiding local problems?
Seems so. Community-level data, even as late as 1979, showed ongoing issues, like younger adults in some Western communities struggling to find a regular doctor or lower insurance coverage persisting in certain low-income areas.
Right, the national average doesn't always tell the whole story. Okay, this brings us to the policy climate back then, around 1981 when the paper came out. It was a tough time, wasn't it?
Oh, absolutely. You had double-digit inflation, high unemployment, these taxpayer revolts like Proposition 13 in California, and just this growing skepticism about government spending and effectiveness.
A really difficult environment to argue for more spending on social programs.
Exactly, and this created serious tension. How do you balance equity, getting care to those in need, with containing costs and maintaining quality?
The classic trilemma.
Precisely. Programs like Medicaid were praised for boosting access, sure, but also blamed for driving up healthcare costs. The paper even notes that by 79, the number of Medicaid recipients seemed to be declining, suggesting maybe access barriers were creeping back in as budgets tightened.
Wow. So does this lead to the paper questioning that fundamental idea of healthcare as a right?
It raises the concern, definitely. In that kind of economic and political climate, the authors worried that the focus might shift away from need, that maybe market forces or ideas about merit or societal contribution might start creeping back into decisions about who gets health care, a potential erosion of that commitment to need-based access.
A really sobering thought from back then. So wrapping this up, what does this deep dive tell you, our listener, today?
Well, I think it shows this complex mix, right? Real progress was made, especially thanks to specific policies, but deep-seated inequities remained. It's a powerful reminder that the debates we're still having about access and cost and quality, they have very, very deep roots.
And maybe a final provocative thought for you to consider. How do those historical forces, those shifts in thinking, is healthcare a right, a commodity, an individual responsibility? How do those underlying currents continue to shape the healthcare system you navigate today? Something to think about.